Welcome to the webinar tonight on ECG organized by the NCT Committee of the College of General Practitioners of Sri Lanka. The topic today is Deciphering ECG in the General Practice, a case-based approach. The resource person is well-known popular cardiologist Dr. Chamara Ratnayake. He is the resident cardiologist and head of cardiology at Asiri Group of Hospitals. Over to you, Dr. Chamara.
Thank you very much, Dr. Pushpa, again for the kind introduction. And thank you very much for inviting me again to deliver a talk on ECGs. I'm happy to hear that the first lecture that I gave had good feedback, and I hope I can continue with the same enthusiasm, I suppose, and hopefully I'll be able to impart some knowledge about deciphering ECGs. So the last time that I spoke a few weeks ago, the feedback was that everybody who listened enjoyed the topic, but I was given some very specific, let's say, ECGs or topics that the fellow general practitioners wanted me to talk about. So I took that into stride, and then I thought, okay, fine, let's talk about certain topics that I suppose were requested to be spoken about. So in the course of the next few minutes, which I will be talking, I will try to, I will show ECGs which were requested and try to help in deciphering them, especially from a general practitioner's point of view. But I must say that certain ECGs, even as cardiologists, we find it difficult to decipher sometimes. It's never perfect. But yeah, it's knowing, as we always tell everybody, even medical students, it's knowing the basics, isn't it? And that's what we always recommend. If you know the basics, then I think we can go forward as well. So a little bit of Sunday wisdom just to start. Just remember that life is full of ups and downs. It's like an ECG. And if you don't have ups and downs, you're not living. So just a little bit of Sunday wisdom I thought might be useful just to get people up and going. I know it's a long weekend, it's Easter, etc. So just remember life is like an ECG. So I just thought before start talking about ECGs in general and those topics that we spoke about, something that's just interesting and something that fascinates me as well. So nowadays there's always this debate about humans and computers, isn't it? So, and most of you who have a general practice, you probably have an ECG machine at your workplace, or you may have got ECGs taken and patients come to you with ECGs. And more often than not, you get these computer-generated diagnoses as well at the top, on the side or whatever. Sometimes patients come to it and they read it themselves, and they are highly worried once they read something like that, the interpretation of the computer that takes the ECG and whether it's correct or not, and you get various diagnoses and various numbers and etc. But how accurate you reckon that these computer-generated diagnoses are? It's something that always I kind of wondered, and I thought I'd just do a bit of reading on it myself. And there's a lot of data about it as well. But there was a Danish study that fascinated me as well. They took quite a lot of numbers of ECGs, and they tested it, the computer-generated diagnosis versus what general practitioners came up with as far as the diagnosis is concerned as well. I thought that would be appropriate for this audience as well. And you could see here the ability to detect an abnormal ECG was GPs versus an ECG recorder. You can see the sensitivity of diagnosing an abnormal ECG from a general practitioner's point of view was less compared to what an ECG recorder or the computer mentioned. So in essence, this means that if the sensitivity is low, there is a high rate of false negatives. So essentially the general practitioners in this study, the Danish study, there were a lot of false negatives. So there were a few missed diagnoses, let's say, of certain diseases which were found on ECGs by GPs. So there were a lot of false negatives. However, if you look at the specificity, you could see that the general practitioners, the percentage is higher than the ECG recorders. So essentially what it's saying is that ECG recorders have a higher percentage of false positives. The fact that the specificity is less is that there are a lot of false positives. So that's, and the GPs have a higher specificity. So the fact that's, and according to the study, if you read the discussion also, they say that that's reasonable because we want a computer to be able to catch certain things and to exclude diagnoses, etc. And it's up to the general practitioners to be able to see whether the computer has got a false positive and to be able to decipher it and treat the patient otherwise. Because sometimes if you look at these ECG machines as well, and you have seen them yourselves, that sometimes when you get these diagnosis of an acute myocardial infarction, you read it on the computer, it says acute myocardial infarction, and the patient sees it, and etc. And everybody's worried. But sometimes the computer may have a false positive diagnosis as well. So it's up to us as humans to be able to decipher it. And always remember, as humans, we have an advantage. And that's something that I always put into mind as well. So clinical judgment. So the computers cannot judge clinically. So we have that advantage. Clinical judgment will always supersede any advantage a computer may have as far as medicine is concerned. And this quote that I've used in quite a lot of my talks in the past. I used it in the previous lecture that I gave as well. And it's something close to my heart. And it's by William Osler, as you heard me before. Listen to your patient, he's telling you the diagnosis. So clinical history and clinical judgment will always supersede anything that a computer may be able to give us as a diagnosis. And always I believe that if you can differentiate between normal versus abnormal, I think that's going to be the best way to be able to come to any clinical judgment. And that's for any investigation, any way in life, I suppose. If you can differentiate between a normal and abnormal, even if you are unsure of the diagnosis, let's say you find that this ECG is abnormal, you can refer the patient for more specialized care. So as far as an ECG is concerned, I don't know whether a lot of people have heard this 10 rules of a normal ECG by Chamberlain. So if you know these 10 rules, I know it's not easy to remember all 10, I suppose, but if you have a reasonable memory about what a normal ECG should have, then we can detect it and we know what is abnormal. So what are these 10 rules? I'll just quickly go through it because, again, as I said in the first lecture as well, I'm not here to talk about what an ECG is and how to come to a diagnosis, but I thought it's important just as a baseline to know how to differentiate between a normal versus abnormal ECG. So a normal ECG, rule 1, the PR interval should be between 120 to 200 milliseconds, or in other words, 3 to 5 little squares. So that PR interval should always fall into that category. It should be between 3 to 5 small squares. Rule 2, the width of the QRS complex should not exceed 110 milliseconds or 3 small squares. Again, essentially that's saying that the QRS complex should always be narrow. A normal ECG will always have a narrow QRS complex, which should be less than 3 small squares. Rule 3, the QRS should be upright in leads 1 and 2. So the QRS complex should be a positive deflection or upright in leads 1 and 2. Rule 4, QRS should be in the same direction as T waves in the limb leads. So lead L1, 2, 3, etc. The limb leads, the QRS should be in the same direction as the T waves. So if the T waves are going up, the QRS should be going up, and vice versa. Rule 5, and this is important, all waves are negative in lead AVR, and we get some and if you find that anything in the lead AVR is positive, there is something going on. There is some abnormality there. AVR lead should always have everything negative. Rule 6, the R wave must grow from V1 to V4. This is what we call R wave progression. In the chest leads, V1 to V4, the R waves must grow and go up, up, up. And the S wave must grow from at least lead 1 to 3 and disappear in lead 6, V6. So V1 to V3, the S waves will get deeper. And then after that, it'll get smaller and smaller. And by lead V6, there should be no S wave. Rule 7, the ST segment should be isoelectric, except sometimes in lead V1 and V2, which can be a little elevated sometimes, but in all other leads, the ST segment should be isoelectric. Rule 8, P wave should be upright in lead 1 to V2 and V6, V2 to V6. So remember that. That's an important point, which I'll talk about in some examples as well later on. So the P waves should be upright in lead 1, especially lead L1 and 2, V2 to V6. I'll give you some example as to why as well. But remember that point, very, very important. Rule 9, there should be no Q waves or very tiny Q waves in leads 1 to V2 to V6. There should be no Q waves. And the last rule, that the T wave must be upright in leads 1, 2, and V2 to V6. So those are your general 10 rules. So if you were to take I suppose, a picture of whatever the next few things, and if you want to remember what a normal ECG is, this is the picture that you need to have in your head. And if you know what a normal ECG is, as I said, you will be able to know what abnormal is. So I'll take the next few minutes to discuss obviously some abnormal ECGs, and that was the request as well. And as I said, the best way to learn ECGs is to go on a case-based discussion. So let's talk about certain patients who come to us, cases, and the relevant ECGs, and what we find interesting as well. So let's talk about the first patient, 45-year-old lady, presented to the peripheral hospital at 2 o'clock in the morning. I did present this recently at a lecture at the Sri Lanka Medical Association. I do apologize if anybody listened to that lecture already, but I thought it's an important one to start with. But I promise that the other ECGs that I'm talking about are new ones. But this one I thought is important. It is the carbon copy of what I presented, but hopefully not a lot of who are present today in this audience didn't hear that lecture. So it was triggered by an argument with her husband. The blood pressure was 130/90, heart rate was 96, that was fine, and this was the ECG. So this is in a peripheral hospital emergency unit. The ECG was taken. So what do we see here? We see, as you know, and remember, there's 2 o'clock in the morning, everybody's sleepy, doctor's sleepy, everybody's sleepy, yeah? But I suppose as far as prominent abnormalities are concerned, we can see that there are, if you look at the ECG, the main thing that we can see is there's T inversions, isn't it? L1, 2, AVL. So as we go back to those rules, so that's abnormal to see T wave inversions in those leads. So what happened? The diagnosis of an acute coronary syndrome was made by the doctor there, and patient was given load-in doses and transferred in an ambulance to the closest general hospital for specialized care. And a repeat ECG was taken at this main hospital. And what has happened? And if you look at this ECG, first glance, it looks quite normal. There is absolutely no abnormality there. If you can go back to the previous ECG where there were T inversions in lead L1 AVL, 2, 3 AVF, etc. All those changes have reverted. So what has happened? What is your diagnosis here? Why has it suddenly from abnormal to normal? Why has it suddenly changed? So the thing that I remember, what you should look at, and as I said, if you look at the rules, Rule 8 in Chamberlain's 10 rules of ECG, the P wave should be upright in leads 1 to V2 to V6. And in this ECG, you can appreciate the fact that in lead L1, this P wave is inverted. And if I were to go further on, you can, if you look at, appreciate the axis, that the QRS complex is negative in lead L1 and positive in AVF. This is a right axis as well. So this, what has happened, there is, whenever you see P wave inversions in lead L1, remember this, if there is a P wave inversion in lead L1, your diagnosis would be one form of a dextrocardia. And as you would have learned and heard, there are two types of dextrocardia, the so-called technical dextrocardia, which is limb lead reversal, or true dextrocardia, where the heart is on the right side. So when the ECG was taken at the main hospital, things have reverted back to normal. So the diagnosis here is limb lead reversal, that whoever took the ECG at the peripheral hospital has mixed up the left and the right, and that's why those changes were there. And how do you differentiate this limb lead reversal dextrocardia versus true dextrocardia? That's important. So this is an ECG example of a patient who has true dextrocardia, where there is a right-sided heart. And again, you would appreciate the fact that in lead L1, there is a P wave inversion. P is inverted, and you get a negative QRS in lead L1 and a positive in AVF. So again, a right axis deviation with a negative P wave in L1. But the way to differentiate on an ECG, of course, the best way and obviously the smartest way would be to examine your patient for dextrocardia. You would obviously find that your palpation and auscultation, the heart is on the right. So that has to be the first way to be able to decipher whether your patient is having dextrocardia or not. That's a smart answer, I suppose. But if you're looking technically and primarily on the ECG only, again, we will be able to differentiate between true dextrocardia versus limb lead reversal or technical dextrocardia by looking at the chest leads. So again, if you remember, obviously, when your chest leads are placed, they go lead V1 to V6 from parasternal up to the left axilla. So again, if you look at remember the rules, rule 6, that R wave must go up, V1 to V4, because your heart is going that way. And in this patient who had the technical dextrocardia or the true dextrocardia, the technical or limb lead reversal dextrocardia, you can appreciate that V1 to V6, the QRS complexes are getting taller and taller. However, in a patient who has true dextrocardia in this ECG, you can appreciate that there is poor R wave progression, V1 to V6, the R wave. So the tallest R wave is in V1. And as you go further down, you would see that the R waves are disappearing. And that is obviously the case when you are going, the heart's on the right, but the leads are going towards the left. The R waves will be not progressing as much. So that's the way to differentiate whether your patient has, on an ECG, whether your patient has true dextrocardia or is it a limb lead reversal. So in limb lead reversal, you get a P wave inversion in L1. However, there will be good R wave progression. But in true dextrocardia, see, again, you will have a P wave inversion in lead L1. However, it will be associated poor R wave progression. So that is important. And I put that first because it is a mistake that we sometimes make, especially if you see a patient in the middle of the night, sleepy, etc. We see all these, our eyes go to the most prominent finding, isn't it? And that T wave inversion, as you saw in that ECG, in the emergency unit, our eyes go to that initially and we think, okay, this is a T inversions, this is an acute coronary syndrome, non-acceleration MI, everybody gets activated. However, we miss the simple small point of that P wave inversion sometimes. So always pay attention to the minor details. Look at the P waves in L1 always, at least. You don't have to look at other leads, but look at the P wave in lead L1 in normal, in a normal heart, or if your leads are correct, that P wave should always be positive in lead L1. Right. Let's move on to another patient. So we have a 30-year-old man who presents with a history of recurrent syncope or transient loss of consciousness over 3 months. Each episode is lasting a few minutes and was preceded by palpitations. Examination was unremarkable. Again, an ECG was taken. And this young chap, 30-year-old ECG. Again, the most prominent findings, you get and eyes go to certain thing. Your eyes probably will go to the chest leads here, V1 to V2. We notice and appreciate that the ST segment is elevated. So again, when you see this ST elevation, sometimes we get activated thinking this is myocardial infarction. But remember, the history was not chest pain. The history was syncope. It was loss of consciousness, not chest pain. And it's a young chap. So don't always go by the ECG. As I said, always correlate with the history. That is very, very important. Don't get distracted by what you see on an ECG, and don't forget the history. Patient is coming with transient loss of consciousness, and you see an ECG like this. So the shape of this ECG is a typical what you call cove shape ST elevations in lead V1 to V2. But sometimes you may think, okay, is this an ST elevation myocardial infarction? Not impossible, but not really as well. The history is not adding up. However, if you remember from my previous talk as well, that we spoke about myocardial infarctions, ST elevation myocardial infarctions in particular. Remember, if your patient is having an ST elevation myocardial infarction, the ECG changes will be dynamic over time. So in essence, if you thought this is a myocardial infarction, the safest and easiest thing to do would be to repeat this ECG in 15 minutes, in half an hour, in 1 hour maybe. And if it is indeed a myocardial infarction, that ST segment changes will change. It will be dynamic. It will be higher, lower, etc. If it remains static, that means this is not an ST elevation myocardial infarction. This is something else. So let's see for argument's sake, we repeated the ECG in this patient, and it's exactly the same. There is no dynamic changes. The ECG remained the same. So what is the diagnosis here? So you get the typical coved shaped, and in a patient who has got a young patient who has got a history of syncope, this is the so-called Brugada syndrome. So this was one of the requested ECGs, so that's why I thought I'll talk about it as well. There was a request to talk about Brugada syndrome. And funnily enough, Dr. Brugada himself was in Sri Lanka about 6-7 years ago. He came to the College of Cardiology sessions as the chief guest. And all of us cardiologists were, it was as if a celebrity came to Sri Lanka actually. But he himself said sometimes he himself won't be able to recognize a Brugada ECG. That's what he said. But anyway, the typical Brugada pattern on an ECG, you get so different types, type 1, 2, 3, as you can see on the screen as well. The typical type 1 Brugada, which is the most common type of Brugada syndrome, which is a sodium channel channelopathy, as we call it. You don't need to know the technical details here, but essentially it's a genetic condition where there is sodium channel block in the myocardial cells. You get that typical coved shaped ST segment elevation, and in particular, you get it in leads 1 to 3, V1 to V3, and prominent in lead V2 generally. And in type 2 Brugada, it's a bit different. You can appreciate that it's a so-called saddleback, so concave shaped ST segment elevation, in particular V2. And the type 3 Brugada, again, the same saddleback appearance is there, however, without any ST segment elevation. So that's the difference between type 2 and type 3. The shape is the same, but in type 2, there is ST elevation, but in type 3, there is no ST elevation. But the more common one is type 1, the so-called coved shaped ST segment elevation. The differential diagnosis, and I think this is the important point as well. There is a differential diagnosis for a Brugada-like ECG. So Brugada type or Brugada-like ECG. And this happens when there is incorrect chest lead placement. So that's important, I think, also in general practice to be able to know and to look in whenever you see an ECG that looks something like the Brugada ECG that I showed, in particular type 2 Brugada, if I were to say so as well, type 2 Brugada, that not the cove shape, but the saddleback shaped ST elevation. you can get it if the chest leads are superiorly placed. And you can see in this ECG, the typical place to have V1 and V2 chest leads in particular will be 1, 2, 3 for the fifth intercostal space there. But if it is higher, maybe in the fourth intercostal space or so, you can sometimes get an ECG looking like the typical Brugada pattern. You can appreciate on the top ECG, this is an ECG that was taken if the V1 and V2 leads were superiorly placed. And this is the type of ECG that you might get. And if you change it and if you bring it back to the fifth intercostal space, you will see that this is the ECG at the bottom that has come back to normal. So this is something to always think about. If you have an ECG like that, make sure that the ECG leads V1 and V2 have been placed in the correct position. And also the P waves in V1, as I said, V1 should be the P waves in V1, V2, you can appreciate the fact. And if you see a V2 in lead V2, if the ECG lead is placed superiorly, you will not get a positive P wave in V2. It will be negative because the current is going in the opposite direction. You get a negative P wave in lead V2 as well if the lead V2 is placed too superiorly as compared to normal. So then we move on with the same patient. I thought I'll make it a little interesting. I'll talk about the same patient as a story. I thought that will make it a little bit more interesting as well. So this patient who had a syncope, and we had a Brugada type ECG, Brugada type 1 ECG on presentation, had a 24-hour Holter monitor done. So as we know, a Holter monitor is done to detect cardiac arrhythmias. And this was part of the workup. And then in the Holter monitor, when we were looking at it, this is what we found. What do we see here? A bit of a bizarre pattern, I suppose, but the main thing you can appreciate that this is broad complexes and different morphologies. Different morphologies, the different shapes of broad complexes are there. And then followed by, at the end, you go back to sinuses. So there is an episode, brief part where there is broad complex, polymorphic broad complex tachycardia. And this is what we call polymorphic ventricular tachycardia, or tosa dépend, as the French call it. But in general terms, this is ventricular tachycardia, polymorphic ventricular tachycardia. So this is a very important ECG to remember if you look at a Holter to see it. And the patient after that was offered and implanted an ICD, as we call it, implantable cardioverter defibrillator. And I just thought I'll show you this ECG as well. So after the ICD implanted, sometimes you do get these ventricular tachycardias. Again, you can appreciate that the patient has got this is a bit different now. This is more of a monomorphic ventricular tachycardia where the broad complexes are of the same shape, you can see. And then what has happened here at the bottom, and this spike, that's the ICD firing. The ICD has given a defib spike, and patient has converted back to normal sinus rhythm. So that's the beauty of an ICD. It saves the life by detecting arrhythmias, ventricular arrhythmias in particular, and gives a electric shock. You can see the spike there, and then patient has converted back into sinus rhythm. So that is what an ICD does. Right. In the same vein, let's talk about, so we're talking about bizarre ECG. So an 85-year-old man with Parkinson's disease, again, brought in, let's say, to your general practice, you get 80 elderly men or women who are brought in, elderly patients with different symptoms, cough and shortness of breath. I think it's a common presentation to any general practice, isn't it? The blood pressure is 130 by 80. Pulse rate is 80 beats per minute and regular. I put that in highlights and I'll tell you why. And ECG was taken again. So this was the ECG that was taken at the general practice. So when you look at this ECG again, at first glance, we kind of worry, isn't it? We're wondering, okay, there's a lot going on here. You can see it's quite a bizarre pattern again, if I were to say so. A lot of things happening, a lot of waves, different morphologies, if I were to say so. But what's going on? So if you look at this ECG, you think it's again a tachycardia, isn't it? You think that there are multiple complexes going quite fast. You would appreciate that it's maybe a tachycardia. However, remember that when you examine this patient, the pulse rate was 80 beats per minute. So he was not tachycardic on examination, but when you ECG only. So this is why I say sometimes we overthink and we ignore our own clinical judgment sometimes. So don't always look at the ECG and think, oh gosh, this patient is having a tachycardia, I must do something, etc. Remember, when you examined him, the pulse was normal. It was not tachycardic. So the ECG, there's something else going on. So this is a typical ECG of what we call a tremor artifact. So this is not a true arrhythmia. It's not tachycardia. It's just that because of the patient's Parkinson's. Remember, the patient has Parkinson's disease. Because of the tremors, the ECG is looking bizarre. So always remember, again, the key point here is that ECG should always be interpreted in the context of the patient's condition and our examination finding. Always trust your clinical judgment. That's something very, very important. Don't always go by an ECG. Obviously, ECGs are very important in our diagnostic process. However, they will never supersede your clinical judgment. So whenever you're in doubt, go back to the patient, feel the pulse again maybe, and correlate whatever your clinical findings are with what you get on the ECG, and you will be able to come to a more conclusive diagnosis. So this is a typical that tremor artifact ECG, and you will see these QRS complexes are coming quite regularly in between actually, isn't it? So that is a pressure. So all of these are the small waves that you get see are actually tremor artifacts. Right. The next case is a 75-year-old man is coming with a history of recurrent falls with transient loss of consciousness. Blood pressure is 120/90, but here now we find something different. Heart rate is 30 beats per minute. So obviously this patient is having some sort of a bradycardia, 30 beats per minute, something is off. So now your clinical judgment, and in your head you're thinking there has to be something going on. This patient is having falls and he is bradycardic. ECG was taken. So this is the ECG. And what do we find here? And the classical finding and something to remember here is that what do you get? That there are more P waves than QRS complexes. Can you appreciate at the bottom line here? This is the lead 2 rhythm strip. You can see P waves coming through. So multiple P waves, but only 2 QRS complexes. So more P waves than QRS complexes. So whenever you get an ECG that has more P waves than QRS complexes, remember this is some sort of a high degree atrioventricular block, AV block, and essentially this is what you call a complete heart block or a 3rd degree AV block. So whenever you get an ECG that has more P waves than QRS complexes, this patient is having some sort of a high degree atrioventricular block and most likely complete heart block. And if you get this type of patient in your general practice, you need to refer this patient to an emergency unit for pacemaker implantation. So a pacemaker, a diagnosis of complete heart block or 3rd degree AV block was made. He was referred to a cardiac electrophysiologist and a dual chamber permanent pacemaker was implanted. So as I said, I'm just doing these cases as continuity to make it a bit interesting as a story. And then the same patient comes back to you 2 months later with a pricking type of chest pain that's increased with movements. So again, now chest pain, any patient comes with chest pain, we are worried. Is it an MI, etc.? Blood pressure is 130/80. Heart rate is 60 beats per minute. So the pulse rate is now better. Obviously, it's 60. That means it's not bradycardic per se. And ECG was taken again. This is the ECG that was taken. what do we appreciate here? Again, sometimes if you look at the ECG first glance, we worry a bit. What do we see? We see broad complexes and we think, oh gosh, is it a myocardial infarction again? Because the patient came with chest pain, and chest pain, broad complexes, is it a myocardial infarction? However, again, going back to our mantra, again, listen to your patient. Is that a typical chest pain that he's talking about? No. Typical uh, ischemic chest pain? No, it's a pricking type of chest pain which increase with movement, that is more in line with the musculoskeletal type of history, isn't it? So remember, trust your judgment. It doesn't sound ischemic, but the ECG looks off. But what's going on here? Apart from the broad complexes, which our eyes will always go to initially, we appreciate the fact that before the complexes, you can see some spikes. So before the P wave, you get a small spike, and before the QRS complex, you can see a taller spike. So these are your typical paced rhythm ECGs, where the pacemaker is firing. When a pacemaker is working and firing, you get these notches or these spikes before the complexes. And it's a dual chamber pacemaker, so that's why you get the two spikes, one atrial pacemaker spike, and the second spike is the ventricular pacemaker lead firing spike. So again, whenever a pacemaker is firing and working, the manifestation on the ECG is a broad complex, because we are pacing the ventricles, and you will always get broad QRS complexes if your pacemaker is working. So always look into the finer details whenever you get a complex, given the patient's history as well. Patient has had a pacemaker before, and you get a broad complex on the ECG, think whether this is a pacemaker rhythm, and look for these spikes. They will be quite prominently seen. So nothing to worry. I would have reassured this patient, given some painkillers, and sent him home. Right. Now we are going fast forward. We are going into the future. The same patient presents 8 years later. Now we are well into we are older, patient is older and as well, and we are also older and wiser. So from 75, 8 years on, the patient is in his mid-80s, I suppose, and he's now had a fall and loss of consciousness again. Blood pressure is 110/70, and that heart rate, oh no, it's back to 30 beats per minute. So something is going on. What's gone on? And this was the ECG again. And what do we see? Again, we see a lot of P waves, and sometimes P waves more than QRS complexes. And we see some spikes here, though, isn't it? In lead V4, V5, we are seeing some spikes. And in lead V3, we see spikes. So this spike is followed by a QRS complex, a broad complex. This spike is V3. It's followed by a broad complex. But these spikes in V4 and V5 are not followed by a QRS complex. And you can see a spike here in the middle as well. So something that is pretty much, the pacemaker is not working anymore. There's a malfunction, failure to capture. Probably the battery life of the pacemaker has ended. So this is what we call failure to capture. Essentially, there is a spike, but the pacemaker is not giving enough energy to produce a QRS complex. So there is something going on with this. So if you see spikes, these on the ECG, you see the spikes, but they are not followed by a QRS complex. Something is going on. You need to refer this patient back to the cardiac electrophysiology. So this is what we call failure to capture. A couple of more cases. Hopefully, so far it's been interesting. A 50-year-old female known to have diabetes presented with a history of intermittent chest pain for 5 days, and the pain radiated down the left arm and increased with exertion. So if you go by the clinical history, if we were to give it in simple terms, this is an ischemic sounding chest pain in a diabetic patient, isn't it? So that's very, very important in our head. The history is very suggestive and typical ischemic sounding chest pain. Blood pressure is 140/90, heart rate is 70, and the troponin, though, is negative, and ECG was taken. So this is the ECG. Again, the main finding or the abnormal finding here is in the chest leads V1 to V4 in particular. And what to look at here is that we can see that the ST segment goes up like that, but here we get the so-called biphasic. The T wave is going up and down and up. So this is what we call a typical biphasic pattern of ECG, where the T wave is going up and down and up, biphasic T wave inversions in the anterior leads V1 to V4. And this is a patient who's got what the so-called Wellen's syndrome, an acute coronary syndrome in its own right. And remember, Wellen syndrome is a form of unstable anginas most often, and the troponin is negative. A patient has a coronary angiogram, and this is the left anterior descending artery, and you can appreciate the arrow here. There's a significant narrowing in the proximal left anterior descending artery, and the patient had a stent and fixed, and that ECG reverted as well. So this Wellen syndrome was termed by, he's a Dutch cardiologist, cardiac electrophysiologist in particular, Heinrich Wellen. So he termed this because it was a pre-infarction state. So again, remember, so if the importance is that the patient has not had a myocardial infarction as yet. So that's the importance of catching it early. We can prevent a myocardial infarction from occurring. And the typical ECG is a T wave abnormalities in the anterior leads, chest leads, symmetrical deeply inverted T waves or biphasic T waves in lead V1, 2, 3, 4. So that's the typical Wellen's syndrome ECG. But remember, it's pre-infarction, and these are generally associated with this critical obstruction of the proximal left anterior descending coronary artery. And it's important in the, as I said, discovering it, because 75% of these patients will go on to develop an acute anterior myocardial infarction if we do not treat it in time, and this will happen within a week. So that's the importance. If we catch it early, we can prevent myocardial necrosis and damage. So the same patient, so had a stent, remember, found to have a block, left anterior descending, had a stent, and 2 months later comes back with severe central chest pain again with sweating. So again, now alarm bells are ringing. If I was the cardiologist there, I would have been really worried, because our worst nightmare is always if your patient has developed what you call acute stent thrombosis, or the stent has got blocked. And ECG was taken again. So what do we see here in this ECG? Again, we are concentrating most. We can see, I would appreciate, yeah, there are some ST depressions here, 2, 3 AVF. But the other place that we can see ST depressions here, in particular, in V3, V4, V5, and it's going upwards. It's upsloping ST depressions, upsloping ST depressions, upsloping ST depressions. So this is the typical so-called De Winter's sign. So it's kind of an exception to the rule of ST changes in ECGs. So generally, what we say is, if you get a ECG which has upsloping ST segment depressions, it's a physiological ST segment depression. We don't usually worry too much in these kind of ECGs, but in particular, if you see it in the limb leads, remember that. But if you see upsloping ST segment depressions like this in the chest leads, we worry whether this is the so-called De Winter sign, and this is a sign of likely a proximal occlusion of the left anterior descending artery again. So this patient that we just spoke about probably had a thrombosis or block in that stent that he had before. So that's the typical De Winter sign, where you get an upsloping ST segment depression in the anterior chest leads. So De Winter's was one of those. Wellen's and De Winter's was requested by the audience in the last lecture. So that's why I thought I'll talk about it as well. Right, and this is the one before the last, yes. one before the last case. 20-year-old girl presents with a history of palpitations. Blood pressure is 100/60. Heart rate is 60 beats per minute and irregular. An ECG was taken. So this again is a very common ECG I feel that we get in our practice. I think in your practices as well. And it's important for us to be able to come up with a possible diagnosis. So again, what do we appreciate here? So first things first, remember you can see that we do see narrow QRS complexes. There is something normal here as well, which are preceded by P waves. So in essence, the baseline or background is that the patient has normal sinus rhythm. However, in between these normal QRS complexes, you get these broad QRS complexes coming through as well. And every other beat is a broad QRS complex, which is not preceded by a P wave. So this is a broad QRSs, which look the same. So this is what we call unifocal ventricular bigeminy and RVOT ventricular bigeminy. So there are premature wide QRS complexes with no preceding P wave. And always remember, whenever you get a ventricular ectopic, you will get this so-called compensatory pause. So that's important. You can appreciate here in this ECG as well, that after the ectopic, there is a pause. So that's the reset of the heart, and it's not abnormal. So sometimes we get patients who are referred to us with ventricular ectopics saying that this patient is having some sort of a heart block because there is a pause. But that is normal. That's typical for any patient who has a ectopic beat. After an ectopic beat, there will always be a so-called compensatory pause. That is not a block. It's just the rhythm getting reset. That's basically how the electrical conduction works. Whenever you get an ectopic or an extra premature ventricular contraction, there will be a compensatory pause that follows. So don't worry about that pause. It is normal, and that's just human nature. So I just mentioned about RVOT, right ventricular outflow tract. I think it may be a little bit too advanced maybe, but just for your knowledge, you don't have to remember this, I suppose. But those who are interested in cardiology, let's say, and you want to do cardiology as well in the future, just the difference between, so there are two main types of, there are four types, I suppose, but the common two types of ventricular ectopics, the one is the right ventricular outflow tract, and the other is the left ventricular outflow tract ectopics. The easiest way to differentiate the two will be to look at lead V1. In lead V1, if it's a right ventricular outflow tract, RVOT ectopic, you will get a negative ectopic or negative QRS complex down going V1. If it's left ventricular outflow tract, the lead V1 will have a positive complex. So that's the easiest way to differentiate between RVOT and LVOT ventricular ectopics. I suppose it's important from a prognostic point of view because LVOT ectopics can be very malignant. Sometimes it can lead to very malignant arrhythmias, as opposed to RVOT ectopics, which are less malignant. I would not say they are benign. Always there can be complications from it. But if it's LVOT, generally that is more dangerous, let's say. So as I said earlier in that ECG, the one that I showed, this one is unifocal. The morphology of those ventricular ectopics were the same. They look the same. The shape was the same. As opposed to this ECG, which shows polymorphic ventricular ectopics. The ectopic beats, you can see, again, there are different shapes to the ectopic beats. So this is a little bit more dangerous as well. Polymorphic ventricular ectopics can lead to ventricular arrhythmias more commonly, and they should be referred to a cardiologist for further assessment. Unifocal ventricular ectopics actually are more or less benign. I would say more or less, not always, but generally benign and can be managed medically more often than not. But this may not be. And in the topic of ectopics, I just thought I'd just show you examples of a few other types of ectopic beats. So these are the so-called atrial ectopics. So atrial ectopics, you can appreciate the difference. The QRS complexes, you can see the arrows here, are narrower and they are preceded by a P wave. But they are different as far as morphology is concerned to the normal sinus beats that we get as well. So this is the normal sinus, that's the baseline ECG, and that's the atrial ectopic. So you will appreciate that the P wave morphologies are different, but in atrial ectopics, it's a narrow complex which is preceded by a P wave of different morphology. That's what an atrial ectopic is. And then the other type of common ectopic is the so-called junctional ectopic. Again, arrows show the junctional ectopics. You can appreciate it's again a narrow complex extra premature contraction, but not preceded by a P wave. So that's the difference between an atrial ectopic and a junctional ectopic. You get a narrow extra beat, but no preceding P wave. However, you will always get that compensatory pause. So those are your common ectopic beats that you may encounter when you take ECGs in your general practice as well. Right, the last patient that we are going to talk about today, and then we'll give some time for questions. It's a 30-year-old man, again, a history of palpitations. Blood pressure is 120/90. Heart rate is 170 beats per minute. So remember, whenever your heart rate, patient's heart rate is above 120 beats per minute, it should not be technically sinus tachycardia. Sinus tachycardia does not go beyond 120 beats per minute. Whenever it's beyond 120 beats per minute, something else is definitely going on. An ECG was taken, and this is the patient's ECG. You will appreciate the fact that this is a tachycardia, narrow complex, regular. So narrow complex, regular tachycardia with no preceding P waves. There are no P waves to be seen here. So this is a typical supraventricular tachycardia, SVT in short. So definition is a narrow complex tachycardia, regular with no preceding P waves. Narrow complex regular tachycardia with no preceding P waves is an SVT until proven otherwise. Adenosine was given in the emergency unit and a repeat ECG was taken. This is the ECG after adenosine, which is the drug of choice unless it's contraindicated. So this, you can see that now you can see some P waves. So basically back to sinus rhythm, but I just put this ECG just for knowledge sake as well. Although we see a P wave, what we notice is that the PR interval is very short, isn't it? So the P wave is almost just immediately after, followed by a QRS complex. So the PR interval is short. And also, if you would appreciate, the QRS complex has a notch. So this is the so-called delta wave, as we call it, the notch in the QRS complex, a delta wave with a short PR interval. And this is the typical Wolff-Parkinson-White syndrome, WPW syndrome. So this patient had an accessory pathway that led to the SVT, the supraventricular tachycardia, AVRT, atrioventricular reentry tachycardia, accessory pathway, and this is the so-called Wolff-Parkinson-White syndrome. The best way to diagnose is with a short PR interval with a notch in the QRS called the delta wave. So I know so those are my cases. Thank you for your patience, and hopefully you found them interesting. As I said, I try to make them a little story-like and try to get the ECGs that were requested by certain individuals after my previous lecture. So hopefully I managed to speak about and talk about the ECGs that were suppose a lot of people are keen to learn about. And if you have any questions, I suppose we can give about 10 minutes, Pushpa. What do you say?
Yes, they can ask questions. So
hopefully that managed to cover the topics that were requested.
Yes, yes. So any questions, please?
I suppose a lot of people will be asking questions on the chat, isn't it? So you might have to read the chat.
Yeah, no, that is somebody is thanking for the excellent lecture.
Ah, okay. My pleasure. Thank you very much. Thank you for the compliment. Thank you.
You can put it in the chat box. No, all are saying thank you.
No questions, please. I'm sorry.
Is a-
They always say if there are no questions, it's either everybody understood
Yeah.
everything, or nobody understood anything.
No, one thing I want to ask Dr. Chamara now about that patient who had 30 minutes and then you put pacemaker. Yeah.
Yeah.
So on the yeah. So now, if we say don't worry, now he came back with the pricking chest pain. No? So
Correct.
if they are not satisfied, if a GP says, I mean, it's normal sometimes. So I mean, it's better to refer, and then if
I
the
suppose, yes.
cardiologist.
I suppose if your patient is worried as well,
Yeah.
there's no harm in referring the patient to the cardiologist. But
Yeah.
again,
Not in a hurry, but can ask them to go and see a
the
cardiologist.
reason, yeah, I put that ECG essentially for everybody to understand that sometimes when you see this ECG, this one in particular, as you said, so when you see this ECG, a lot of people worry, including general practitioners. I've had a few patients who are referred to me as well, patients who've had pacemakers, who got this ECG done, and they worry that this is a broad complex. Is it a myocardial infarction? Patient comes with this chest pain. To remember, the reason I put it also is that you can reassure, but if you're unsure, you can send the patient over, of course. But the reassurance is that a pacemaker patient will always have this type of broad complex. However, remember, the broad complexes will be preceded by that pacemaker spike. So that it's just not purely a broad complex alone. It has to be preceded by that spike as well.
Okay, thank you. So any other questions, please? So there are no questions. So they must have. I mean, they are happy, and there are a lot of appreciations.
Either they understood everything or they didn't understand anything. So hopefully it's the former.
So thank you very much, Dr. Chamara, for your time and
My
for the
pleasure.
comprehensive lecture. So thank you very much for joining everybody. And then we will upload this recording. There's one question.
Sure.
There's one question.
Why not?
Yeah. What is the etiology of what is the etiology of rethrombosis and how can it be prevented?
What is the etiology of stent thrombosis, I suppose?
Yeah, rethrombosis. Yeah, rethrombosis and how can it be prevented?
So the most common cause for acute stent thrombosis is non-compliance with antiplatelets. If I were to say so, that's probably the number one cause. Because now after a stent, we prescribe patients dual antiplatelets, generally aspirin and clopidogrel. The nightmare for us is that it does happen, and the commonest etiology is non-compliance with antiplatelets. The other possibilities, of course, is that from a technical point of view, if the stent was not expanded properly and there was calcium, etc., and the stent deployment was not done properly, etc., that could lead to stent thrombosis as well. However, the commonest cause is non-compliance with medication. So the way to prevent it is to make sure that your patient takes the antiplatelet as prescribed.
So any other questions, please? So we will finish the lecture now. Yeah. Okay, thank you very much. And we'll be uploading this recording after editing, I think, on Monday or Tuesday. So thank you very much, Chamara, for for the valuable time you spent with us. And thank you very much and good night, everybody.
Thank you. Good night, and hopefully everybody did understand whatever I spoke about.
No, lot of appreciations. Always thank you and nice lecture. Very big thank you. Very interesting and understanding. So all appreciations.
Fine, no problem. Thank you very much. Thank you.
So there's one Ayodhya. How to identify AVR STEMI specifically?
AVR STEMI, good question. So again, as the name suggests, if you get a patient who has AVR STEMI, you get, so again, remember that if I were to go back to the rules of ECGs, the Chamberlain's rules, rule number 5, all waves are negative in the AVR. AVR STEMI essentially is the opposite of that. You get everything positive in AVR. The P wave is positive, the QRS complex is positive, and STs are going up, ST elevation obviously, and T wave is also positive in AVR. Whenever you see that your suspect in the clinical context, remember always, patient comes with a typical ischemic sign of chest pain and you get all positive waves in AVR with an ST elevation, most likely that is an AVR STEMI. However, the other finding you get is that generally you will find that there are ST depressions in all the other leads. In AVR STEMI, generally it's always AVR has an ST elevation. However, all the other leads, there will be ST depression. And again, more often than not, an AVR STEMI is because of occlusion of the left main coronary artery, or if not, the very proximal left anterior descending. More often than not, it's involvement of the left main coronary artery.
Okay, thank you very much again. And then good night, everyone.
Thank you and good night. Thank you for inviting me again. Thank you.